talk about some of the formulas and how they, correlate with this anatomy physiology, right? So you guys probably heard, right? You have cardiac output, and the formula you probably had in your book is heart rate times stroke volume, right? So let's go through this step by step. So what would you say is a normal heart rate for any of you guys who are sitting, watching this lecture right now?
80.
80, right? 70 to 80. So I'm gonna say 70, right? 60 to 100, right? I was gonna expect the answer. Hopefully it's not 100, right? You don't have a tachycardia watching this lecture. So 70 to 170 beats per minute. And your stroke volume is roughly also about 70 ml. I'll show you how we get this number, but 70 ml is roughly your stroke volume. That's how much blood is ejected, right, with the contraction of the ventricle. So 70 times 70, right, is 4,900 ml, right? Makes sense? If I move my decimal place three places, it's going to be 4.9 liters, right? I'm just going to say 5 liters just to make the number round. So your normal cardiac output is about 5 liters, right? For a person who is not under stress, who is not doing any physical activity, right? And that the way they derive this cardiac output, they basically take the heart rate times stroke volume, right? So now how does it correlate? So initially, let's say we use exercise. If you start to exercise and your heart rate increases, let's say your heart rate now becomes 100 beats per minute. 100 times 70 becomes 7,000 ml or 7 liters. So my cardiac output is increasing, right? And that's good, right? I'm sustaining now the blood supply to all the organs, muscles, whatever it may be. Now, what happens in, let's say, in your heart attack, right? Let's say, right, you sustain a heart attack, let's see what happens to your cardiac output. Let's say you sustain a heart attack and your stroke volume now drops to 40 ml. And you are right, trying to compensate, but your heart is not doing such a good job, right? Let's say the patient is on beta blockers, right? Let's say the heart rate still remains 70. It doesn't really jump up because the patient is on beta blockers. So what is your cardiac output now?
2,800.
Yeah, 2,800 ml, so 2.8 liters. So now your cardiac output drops, right? So this we saw, right? Your stroke volume diminished. But then you may also have a state, right? You may have a state where, let's say, remember we talked about patients sustain, let's say, infarct on the right side of the heart, right coronary artery, which is supplying the SA node. And all of a sudden he becomes bradycardic. So your cardiac output is heart rate times stroke volume, right? And all of a sudden your heart rate diminishes. Let's say your heart rate all of a sudden becomes 40, right? And your stroke volume is 70, right? Let's say it's still doing that. But your heart rate is 40, right? Same number, but for different reasons, right? Your heart rate diminished. So depending on what part of your system is affected, right? We're going to address a certain parameter. So for example, you're going to learn, right? In a case like this, right, where you have bradycardia, you may give a drug like, well, let me ask you, what kind of drug can you give in this case, for example? Your heart rate drops. You have a bradydysrhythmia.
Atropine.
Yeah. Right, you have bradycardia, you give atropine, that blocks the parasympathetic system. Hopefully your heart rate will increase. Same thing, right? We can do transcutaneous pacing. We basically have this pacemaker machine. We place pads on the patient's chest, and we're going to manually set this number, hopefully increase this number so that you get the optimal stroke volume. On the other hand, let's say you had a patient who sustained, a heart attack, right? And it was on the left side, and right, their cardiac output is down. Let's say they're trying to compensate. Let's say their heart rate increased to 96, but they're significantly reduced stroke volume. Let's say it's 20, right? So stroke volume is 20. So what do you think we may do for such patients?
A stent.
Increase fluid.
So yeah, so correct, right? So in those patients, right, you may want to consider giving IV fluids, right? And you may want to consider giving pressors. So this could be your cardiogenic shock. Right? So who could give me, I just show you some things. So who give me some of the examples what causes cardiogenic shock?
Is it? I think it's like increased myocardial oxygen demand.
No, but give me examples. Like, what can cause cardiogenic shock based on just the examples I showed you here?
Tamponade?
What?
A tamponade?
A tamponade is an obstructive shock. It's not a cardiogenic shock.
Can trauma like a contusion cause it?
Contusion. So it may, but based. Like, let's stick with basics. What do we have? What do you see here so far?
So,
no, a severe heart attack causes cardiac.
Excellent, right? Severe heart attack because the heart is not going to pump well. Severe tachycardia can cause it. Severe bradycardia can cause it, right? Failure to pump, right? Pump failure can cause it. So why bradycardia causes it? Because we drop the heart rate. So bradycardia can cause cardiogenic shock, right? Very, very significant heart attack on the left ventricle can cause cardiogenic shock because the left ventricle is no longer pumping. So myocardial infarction can cause it. Why does tachycardia cause cardiogenic shock? So let's say my heart rate is now 180 beats per minute.
Isn't it because the ventricles don't have time to fill?
Excellent, right? So the ventricles don't have time to fill because when does blood come into the ventricles on diastole, right? Diastolic phase when you get that preload. So if I make my heart rate 180, I decrease your what? Your diastolic time. I decrease your diastolic time, right? Your heart, so you have your cardiac output. Heart rate is now 180, right? So your cardiac output will drop. Why? Because your stroke volume is now diminishing. Why is your stroke volume diminishing? Because this heart pumping so fast, I have no time to fill, right? So cardiogenic shock, some of the basic causes you should keep in mind: severe bradycardia, severe tachycardia, and myocardial infarction, right? Now, anything like tamponade, right? Pulmonary embolus, tension pneumothorax, those are obstructive states of shock. Those are not cardiogenic causes of shock. Right. So here they give you a different number. They give you heart rate of 75, stroke volume is 80. I assume their math is correct. It gives you 6,000 mLs per minute, which is 6 liters, right? So this is your formula, right? So formula being cardiac output equals heart rate times stroke volume. This becomes very important when we give medications like atropine, when we give pacing, right? When we give pressors for cardiogenic shock, when we give IV fluids. So this is what you're manipulating. You're manipulating either this variable or this variable in order to get our cardiac output up. Make sense? Any questions about this formula? When I get to a more involved stuff soon. All right. So that was that formula. Now, the way the propagation of impulse works in your heart, right? We said goes from the SA node to the AV node. Then it goes through this bundle system, and then it goes into your Purkinje fibers, essentially to your right and left ventricle. The sino-atrial node usually depolarizes at 60 to 100 beats per minute. AV, right, about 40 to 60. And then your Purkinje system here, 20 to 40. Why are these numbers, why is it important to have these numbers in mind, especially when you're going to start learning about EKGs and basic dysrhythmias?
Well, if the heartbeat is low, you know where what pathway is taking over. Yes.
So Aaron, you're correct. You're on the right track, right? Because all of a sudden, I look at the EKG and my EKG rhythm shows me a heart rate of 30, right? Is it coming from the SA node? Absolutely not, because the SA node is between 60 to 100. Is it coming from the AV node? Probably not, because it's below that number. So this is how, when I start to interpret my EKGs, I always get the rate, right? We're going to talk about once we get to the skills portion of it, but I always want to get my rate. The rate tells me the number, right? What's the heart rate, right? So the heart rate can tell me, right, where the origin of your impulse is. So as I know, it's 60 to 100, AV 40 to 60, right? The Purkinje or the ventricular system is 20 to 40. These numbers I would commit to memory, right? And then my other question is, right, as the impulse propagates here, right, your atria depolarizes, goes to the AV node, but then there's a pause when it comes here, right, at the AV bundle. Why is there a pause? And usually when we look at the EKG, right, this pause is usually this portion here.
Because the Purkinje not the Purkinje fibers, it's insulated, so the impulse doesn't it contracts after it gets to Purkinje fibers.
But why is there a pause? Why do I need this pause?
For the ventricles to refill?
Correct, said right. So you need ventricles to fill. I need that pause so that I get that atrial kick, right? You have the atrial filling and then the atrial kick, which is from atrial depolarization, so that I get the maximum amount of blood to come to my ventricles. Because when the ventricle starts to contract, I want as much as I can, right? For the stroke volume to basically come out and supply my lungs and my systemic circuit. So this is why we have the pause in the AV node, right? This is the pause that you see on the EKG strip, right? And the reason why I have the pause, right, is for the ventricles to fill. Just curious if you guys know this, right? What is the normal duration of this?
I think it's 12 to 0.12 to 0.20.
Yeah, very good. Second, right? 0.20. So usually if we say, right, if it becomes bigger than 5 boxes like here, right, greater than 0.20, then there's some abnormalities occurring at the AV node. So these numbers are very important also once we get to it, but it's very good. 0.12 to 0.20 seconds. And this is the normal. This is normal. This is how much time it takes for this impulse to come to the AV node and then pass through here, and then it goes to the, to your ventricles, right? So 0.12 to 0.20 is correct, right? Very good. So we talked about that. This is the actual propagation, right, of the impulse. So you see from the SI node, you have these internodal pathways, right, that then go to your AV node. This is where the bundle of is and the AV node is located. You have that pause here, and then goes into your bundle branches. The right bundle supplies the right ventricle, and then you have the left bundle, which has 2 fascicles, right? That has the anterior fascicle as the posterior fascicle, right? Truly, I will tell you this much. You can, on the 12 lead, based on the axis deviation, determine it. For your purposes, right? For your purposes right now, I would not spend a great deal of time to learn that. For your purposes, what I will present you here in terms of ST segment elevation will give you way better dividends in your long run than learning all these axis deviations. And, are they going to be important for you to learn later on, right? Once you become more proficient, probably yes. In the initial phases, learn the basics first, right? So I'm not going to spend too much time about the axis deviation and all that, because I don't think it's really pertinent for your level right now. What you need to know is this. If let's say I have some sort of an infarct where blood flow to this right bundle branch is cut off, right? Do you think this high energy pathway is working well or not? Not, right? So the way your ventricles will depolarize, first the impulse has to go through the pathway where it's functional, like this, and then it will go cell to cell via gap junctions in order to propagate that signal. So this side depolarizes fine, but to depolarize this side, you got to go cell by cell, take a slow pathway. Why? Because this guy has right bundle branch that's non-functional. So that's why you will see some abnormalities on the EKGs. They'll be prolonged, right? The Qrs complex will be longer. Why is it longer? Because one of the bundle branches, either the right side or the left side, is not functional, and you will see that prolongation, right? But on a normal person who does not have any pathological issues, right, we usually see normal, right, Qrs complex, which is usually tight in nature. We see this guy is usually, right, very narrow. But in patients who may have right side, they may have like something like this, right? They have prolonged QR. Why is it prolonged QRS complex? Because if this bundle branch is not functional, by the time this impulse propagates to the other side of the heart, it takes way longer, right? So we see that prolonged point interval. By the way, anyone knows what's the normal QRS duration? We just said for this one, right? For PR was 0.12, 0.20. What's normal for QRS?
It's 0.4 to 0.12.
0.04, 0.12, right? Because if you said 0.4, right, that's too long. Usually, and some books will have it 0.08. Sorry, yeah, 0.08 to 0.12. So anywhere around this number. As long as the top number is under 0.12 seconds, right, or equal to it, you are in the correct ballpark, right? So that means the QRS is tight. There's usually no pathology that's occurring. But the moment this number is prolonged, you may have either right bundle branch block or left bundle branch block, depending on the morphology of your EKG. All right. Something else very important, right? The way you remember how I said your cells usually depolarize with sodium ion trickling in, right? Sodium ion was the major cation for depolarization, not for SA node and not for AV node. For SA node and AV node, the ion that's responsible for depolarization is calcium. Calcium, right? 2+. So that's something you want to keep in mind. So for most myocytes, myocardial cells, right, it's sodium. But for SA node and AV node, it's the calcium that's responsible for that to occur. Why am I bringing this up, right? You guys are going to learn about calcium channel blockers. You're going to learn about administering calcium in certain states. So you need to know, right, where this is occurring, right? So this is just a schematic to show you, right, the propagation of the impulse. Cardiac cells, right, they have inherent abilities to what? That self-excite, all right? They can propagate that signal, right? So we call that excitability. And they can move, right, through conductivity, through these pathways in order to cause the signals to propagate and contraction follow. So electrical activity first, followed by mechanical activity second, right? So SA node, AV node, right? We see that then it goes to the septum, and then it goes towards the apex, right, of the myocardium, goes up there, and then it depolarizes the bulk of your ventricles, and then it goes to this portion, the basis, right? The base of the heart, remember, was here, right? And then you have depolarized ventricles. So that's just how it's occurring. So impulse propagation first with these SA-AV nodes, Purkinje system, and then the mechanical activity of the heart follows. This is just shows you how it looks on the ECG tracing, right? So SA node, right? And then as the impulse propagates towards the AV node, we have atrial depolarization that's going to occur, right? And that is usually seen by the P wave. So atrial depolarization usually seen by the P wave. Then you have that pause in the AV node, right? AV node here, or AV bundle, they call it. And this is the pause, right? The pause that's occurring. Why? Because we want the ventricles to get the entire fill of it. We see this PR interval, which is 0.12 to 0.20. If I were to measure it, it's usually from here to here. And as I measure it, I'll get this number. If it falls within this range, you have no pathology, we should say, it's normal, right? Once that's done, right, that impulse propagates to the right and left bundle branches, right? And this causes the first negative wave, the Q wave that we see. This starts your ventricular depolarization, right? By the way, how come we see the P wave, right? We see the P wave, that's atrial depolarization. How come we don't see atrial repolarization on the EKG?
It's happening on the QRS.
Correct.
Happening too quick.
Correct. So Angel is correct. He says atrial repolarization, right? Repolarization is occurring with the QRS, right? And it's hidden behind. Why it's hidden? Because this is much bigger amplitude, much stronger signal. So yeah, it's hidden, right? So we see it's hidden. It's hidden because these are now contracting, right? And we see this ventricular depolarization occurring with the Qrs complex. Right, Qrs complex is evidenced here, and this is a T wave. This is where you have ventricular repol. So this is where you have ventricular repolarization occurring. atrial repolarization is hidden by the Qrs complex. By the way, normal Qrs duration is 0.04, 0.12. Some books will have it 0.08, 0.12. As long as you remember this number, you are in good shape. Right? So this is basically just a schematic of how it looks, right? You see how they show you from here 0 to 200 milliseconds, right? Why? Because every small box, right, that we count, it is in milliseconds, or you could put it in seconds. So we said 0.12 to 0.20, right? And you could count these boxes in order to obtain it. Every small one, right? 1, 2, 3, 4, 5. So every small box is 0.04 seconds. So if I do 0.04 seconds times 1, 2, 3, 4, 5, I get 0.20, right? So we could see from here, 1, 2, 3, 4, 5. This is 0.20 seconds, but they just say milliseconds. They just move that number by 3 decimal places. I would say keep it in seconds. It'll be easier for you to keep track, right? Qrs duration, I would say from here to here, maybe 2 boxes, right? So 2 boxes being 0.04 times 2 is 0.08, right? And that's fine, right? And that's how, when you're going to be doing your practice strips, that's how you're going to measure your heart rate. That's how you're going to count the boxes and to determine it. By the way, another important thing, right? You see the millivolts, right? So every small box like this, right? When we say elevation, right? When we're going to learn about ST segment elevation, we're going to say 1 millimeter. So that corresponds to 1 millimeter of elevation. The ST segment that we are referring to is this portion here. See how it says S and T? So this is what you're going to be looking at, this portion here, what's going to be elevated for the person who's having a heart attack. So they will look like, for example, let me take a blue color. Let's say if I drew it like this. So and we're going to pretend this is not here. Right? So what you're going to do is from the baseline, right? You're going to say how many boxes it's elevated. So let's say 1, 2, 3, 4. You're going to say there's 4 millimeters elevation. I'll show you better pictures, but basically that's what you're doing when you're saying the person has a STEMI, right? STEMI stands for ST segment elevation myocardial infarction, and that's what you're counting, right? So that's what's important to note, right? So this is just a little bit more in depth, right? It kind of subdivides into where the SI node fires, right? How it goes to the AV node and specific portions of the AV node, right? The bundle of his, and then once it goes into the bundle branches and to the Purkinje network, right? But for your purposes, this is enough to know that this is the AV nodal pathway, and then time frame is 0.12 to 0.20. Right. So that's your basic tracing. All right. We see the QRS. This is your ventricular depolarization. This is your atrial depolarization, and this is your ventricular repolarization. Any questions about this?
Yeah. A nurse was explaining to me the QTC segment.
Yes.
If that's I feel like that's much deeper, right? Is that something we'll get into?
So the QTC is this is the QT interval, right? You see from so if this was the P, this is the Q wave, this was the R, S, T, right? So the reason why they call it the QT interval is from Q to T, right? Now, the QTC is corrected for the heart rate. Why? Because if you have elevated heart rate, this duration will change based on your heart rate. So if you have a slow heart rate, the QTC will be a little longer. If you have a fast heart rate, this will be a little faster. There's a formula you could do it, but most people don't use the formula. What they do is they'll print the 12-lead EKG, and on the 12-lead EKG at the top, if you look at the top where it's like all the numbers, it will tell you QTC and it will give you a number, right? The number will be saying QTC is this portion. So what QTC is basically it's QT interval that's for your heart rate, right? whether you're bradycardic, tachycardic, or normal heart rate, it will show you that. For your purposes, right now, I wouldn't, worry too much about this yet. Why is this important? In the long run, you have medications, right, such as ondansetron that can prolong QT interval. So we give this medication, Zofran, right, for nausea, vomiting. So if you know the patient has prolonged QT interval, they say they have, they know about this. That's medication you want to be very cautious with. If you want to go to the great extent of doing a 12-lead EKG prior to giving you a Zofran, more power to you, right? But QTC is basically QT interval corrected for the heart rate. Here they show you, right, for this diagram. They show you, right, it's about, let's say if this was 200 milliseconds from here to here, it would be 400 milliseconds, right? So 600 ends here, 200 was here. So 600 minus 200 is 400 milliseconds, or we would say it's 0.4 seconds. But this number will differ. This number will differ, right, from person to person, depending on the heart rate. So for now, when you're doing your rotations, I would just grab the 12-lead EKG and look at this, the top portion, what it says.
Yeah, I actually have one from earlier today. I just got off
and the machine
it says 427 milliseconds. So what would be a prolonged QTC? Like, would it be at 500?
Yeah, I would say I'll show you later on when we're in the lab. I'll show you a specific chart, right? But yeah, anything 500 will be prolonged. But I'll show you a specific chart where you could better provide that value based on the heart rate. So there's a chart, like you will approximately say, let's say, what's the heart rate of the person, 65, 70, 75, 80. So it will break it down into those types of numbers. And then going to the right, you will see, if it's normal or prolonged. So it's better to get for the heart rate, not have one absolute number.
Cool.
Okay. Does that make sense?
Yeah, it makes complete sense.
All right.
You actually broke it down really good.
All right.